Well, thanks again for this invitation. Now, for this part, I want to sum up the management for SNAC wrist. SNAC wrist is a condition that is not a frequent condition, so I want to give some reviews on the concept on the scaphoid injuries to understand its complications and how can a scaphoid fracture lead to a SNAC wrist. So we will understand this through the physiopathology, also to understand the classification and the planning of the treatment. Finally, we will compare some alternatives. As an introduction, we have a 45-year-old female patient that comes with wrist pain. In the past 2 years, she felt some loss of grip strength, but she doesn't report any specific personal history of trauma. And we will know that this history is pretty common in these sort of patients. In our office, we can ask this patient to see on an X-ray, and this is what we find. This is an abnormal picture, and we're dealing here with a SNAC wrist. So we need to ask some additional questions, learn how it was developed, and why do these patients come so late at the office? So how does this happen? So a few words on the scaphoid. We know that this is like a peanut-shaped bone in the wrist with three main portions being the distal, the waist, and the proximal pole, which is particularly the troublesome pole due to its irrigation, which is quite popular on scaphoid anatomy. The scaphoid is irrigated from the dorsal carpal branches that comes from the radial artery. This gives over an 80% of nutrition to the scaphoid, and the lacking 20% is given by some volar branches. But in this, in any case, the proximal pole doesn't get enough irrigation, so it is susceptible to non-union or other complications. When there is a fracture on the scaphoid, it can be repaired, but sometimes it is misdiagnosed, it is mixed, or the problem occurred in the proximal pole, or it was well diagnosed but mistreated, or it was treated okay, but anyway it turned into a non-union for its poor irrigation. If there is also any condition like tabacism or any vascular condition, it may also lead to failure, so the scaphoid doesn't heal properly and it leads to an scaphoid non-union. So when this happened, this is a patient after 21 months of operation with a percutaneous screw, but we see that there is still the fracture line and the patient did not recover well. In the CT scan, we can see some sclerotic borders, and when we're dealing with scaphoid non-unions, meaning no arthritic changes because that would be prior SNAC, then you need to solve that either with a non-vascularized bone grafts or with vascularized bone grafts that can be either local, like the Seidenberg or the Soterianus techniques when they use local arteries, or even free grafts like the medial femoral condyle. Of course, this would require a more experienced microsurgery technique. But if arthritic changes occur, and that's the reason of this lecture, we're going for SNAC. SNAC stands for Scaphoid Non-Union Advanced Collapse. Usually, this is the term of evolution after 5 to 10 years after non-union has occurred. The problem with some scaphoid fractures and some non-unions is that they can be asymptomatic or cause just minor symptoms to the patient. So we need to look for previous history of wrist trauma. It can be well tolerated for a long, prolonged time. That will lead to delayed diagnosis, and usually when the patient starts to complain for pain, it's when some arthritic changes have already occurred. It's also frequent that a patient falls with an outstretched hand and complains of wrist pain, but when we see the X-ray, we know that this injury did not happen from this fall, but it happened many years ago. So we need to complete this evaluation with CT scans, MRI, or if possible, arthroscopy. There are other forms of advanced collapse, including the scapholunate, the malunion, and some that have been added recently, including Kienbock's and scaphotrapezoid osteoarthritis. Most of them have a similar physiopathology that consists on this. If we talk about the normal anatomy between the lunate and the scaphoid, they make an angle from 30 to 60 degrees. The scaphoid is the link between the proximal and distal rows, and biomechanically it's what it connects to both of them. It is provided with some stability for the intrinsic ligaments, especially the dorsal scaphoid ligament, which is stronger, and the lunar trochlear volarly. But what happens when there is a scaphoid fracture and the scaphoid node union? Then this angle is lost. The distal portion goes to flexion, the proximal pole goes to extension, and the lunate goes to extension as well. So this linking row has been missed, and this makes the distal row to collapse in the carpal, giving these arthritic changes. So this node union, these arthritic changes will start on the radial styloid, then it can move to the scaphoid fossa, and in this evolution, then it can affect the capitate, initially in the scaphoid capitate space, and then in the lunar capitate space, and finally it can lead to diffuse carpal osteoarthritis. There are classifications, but if we look in the literature about Watson and Bender that classified this was in the mid-1980s, so they were based on plain X-rays, and there are some minor differences, especially on the stage 2, which Bender considers the scaphoid capitate, while Watson only the proximal radioscaphoid. But these are, to the date, there are, I believe, no proper classifications for this, and there are papers that have tried to prove the reliability of these classifications, and well, the conclusion of this is that X-rays are not enough to classify or plan this problem. If we had the MRI for cartilage injury, MRI itself just has a low sensitivity rate. But if we compare this to the arthroscopy, they not always correlate. Arthroscopy is a more important role to evaluate the chondral injuries, and it might be the gold standard, although it doesn't lack morbidity. So it's a tool that you need to know when and how to use it. So according to the staging, if there is a SNAC 1, you can either observate, you can do denervation, that's an option of the posterior interosseous nerve, or do only a radial styloidectomy. Also, if there is only a radial styloid osteoarthritis, you can you can perform a treatment for an scaphoid node union and still get a good outcome. But in the stage 2, when there is already arthritic changes around the scaphoid, then your options are wider. But the most important thing, and we will discuss this a bit later, is the proximal row capectomy and the four-corner fusion. The main indication between them is if there is a compromise in the lunar capitate joint. But when there is compromise in the lunar capitate joint, then a proximal row carpectomy will no longer be an option, and then you may lead for a four-corner fusion. Now, sometimes you mention in a stage 4 or a panarthritis. In that case, total wrist function fusion will be the option when there is a compromise of the proximal row and the radiocarpal joint. So back to our initial case, this is the patient that I was introducing to you in the beginning of this lecture. And if we see the CT scans, then we find some periscaphoid abnormalities. We can classify these as stage 2, and based on the patient's demands, we plan for four-corner fusion. This includes resection of the scaphoid. It can be or without the innervation. Styloidectomy might be an option to diminish that impingement, and when we fuse this, we apply this bone graft, and we choose our method of fixation. It can either be this circular plate. Plates sometimes can be troublesome, especially when they try to extend. So there are some tips to prevent a posterior impingement, like doing a bit of a flexion of the scaphoid, of the lunate. Other options are screws, which are sometimes the main surgeon's preference. You can use staples, or we can use K-wires if sometimes that's what we have available in the hospital. It can be done by a dorsal approach, that can be ligament sparing or nerve sparing. This is how the X-ray will look in the post-operative time and the long follow-up. We know that there are some sclerotic changes around the wrist, but the functional symptoms are still doing fine. The deformity correction is the most important step when doing this four-corner fusion. For this, the lunate that is in extension needs to be reduced to flexion, and the screw can be applied either directly or through the dorsal aspect of the distal radius. Or if you don't want to violate the proximal lunate, you can enter distally from the third metacarpal. It can be done in a single column, in a double column, as explained here, with either 1 or 2 screws. And it can also be done with the wrist arthroscopy, but the learning curve to do a full arthrodesis with a scope is, I think it's quite large. But the diagnosis it's not that much, and that can be a powerful tool. Of course, if you will do an open or arthroscopic fusion of the wrist. It will give you the same advantages of any arthroscopic procedures, even though they are explained in the future, they are quite similar, but the advantages of a less invasive procedure are quite clear. And what can we say about proximal root carpectomy? So this is not a discussion of which procedure is better, but which patient is needed for this procedure. The main indication for proximal root carpectomy is that the proximal capitate is intact, so it will make contact in the lunate fossa in the radius to have this function. If we make a comparison between these two methods in a stage 2, like having an homogeneous group, we can say that proximal root carpectomy can have a better range of motion, but the four-corner fusion will give a better grip strength. So you need to choose a patient. If you are dealing with a younger patient, that possibly a four-corner fusion is the best option. And if you're dealing with an older or less demanding patients, then you can look for a proximal root carpectomy. Satisfaction rates are similar in both of these. This is another study comparing these two procedures, most of them being retrospective, of course, and having similar outcomes. But what we can say is that even in those cases, both are improved. There is reported more complications for four-corner fusions, but this is quite obvious. If you're using screws, plates, or any material, of course, you will have more rates of revisions or hardware problems than if you're using none. So I think this is not a thing to consider, but the patient selection, as I was saying, of what you want to expect to your patient to achieve, either in motion or in strength, because with either one of these treatments, you will sacrifice one of these. So the take-home mention is it's always important to prevent scaphoid complications. So if you are dealing with a scaphoid fracture or a non-union, you need to have a good follow-up so you can act when it's more proper. We know that carpal collapse is a sequence of biomechanical changes that lead to osteoarthritis. You need to get as much information as possible for your surgical planning and consider diagnostic wrist arthroscopy, especially if you want to do a proximal root carpectomy. If you enter with a scope and you evaluate the proximal capitate and you see that it is not injured, then you can continue with your proximal root carpectomy. But you find arthritic changes here, then that no longer will be an option and you will need to do a four-corner fusion. So patient selection is the most important thing. Thank again for this invitation, and this is our hospital. Thank you.